lembrando ao Dr. Armando Lobato, que é meu colega de moderação, se aqui estiver. Então nós vamos dar início a essa mesa, chamando o Dr. Frank J. Criado para apresentar o trabalho de mapeamento de aorta, um novo olhar sobre anatomia na era do reparo endovascular. Tem a palavra, Dr. Frank.
Por la introducción. Esta presentación tiene que ver con algo que nos ha interesado ya desde hace muchos años, comenzando hace unos 11 años, que se refiere a unos conceptos un poco diferentes en lo que se refiere a la anatomía de la aorta torácica en esta nueva era que vivimos de la intervención por endoprótesis. El estado del state of the art en endoprótesis torácicas So now you want me to speak in English?
If it's okay for you.
Okay, can we start all over again then, from the beginning?
Yes, sir.
Can I have the first slide?
Yes, sir.
Okay. It seems that I always start in the wrong language. Yesterday was the opposite of this. Okay, well, let's try again. Apparently they want me to speak in English, which is actually a little bit easier for me and more efficient time-wise. And this talk relates to a topic that has been an interest of mine for more than 10 years. The state of the art of thoracic endograft procedures is such that if you look at the last decade as summarized in this paper that just came out a few months, on the average, it seems that endograft thoracic operators can perform these procedures in a wide variety of pathologies and indications with very reasonable figures for procedure-related mortality and spinal cord ischemia, as you can see there. If you look at that across the board, really these are quite impressive results. Of course, the issue with thoracic endograft procedures is that more often than not, what you see on that slide is not what we have to handle. More than 70% of all of the implants performed are near or in branched segments, either the aortic arch or the visceral segment of the aorta. 10 years ago, with Professor Ishimaru in Japan, we proposed this zone mapping of the aortic arch that actually has been embraced essentially all around the world and has become the standard for reporting of these procedures at this time. A year ago, we published an update with a more clear definition of this zone mapping. This appeared in the Journal of Endovascular Therapy. We noted there that this classification has been driven by anatomy, of course, but particularly by the needs related to the endograft procedures, and to some extent by the geometric anatomy, for instance, at the apex of the aortic arch that very few people know defines the distal extent of zone 3. We can successfully apply these ideas and zones to most patients, but there are some challenges, as you can see in a quick sampling of procedures and anatomy that we all see in our daily practice. More recently, also, and in that same paper, we proposed for the first time a similar way of looking at the vascular anatomy of the abdominal aorta and the thoraco-abdominal segment, the so-called visceral zone map. And you will see that I have used the same way of thinking as has been established for the aortic arch, where V3, for instance, is the so-called vulnerable zone, where the origin of the artery of Adamkiewicz is expected to be in about 75% of individuals, and is equivalent to zone 3 for the arch. V2 is a celiac artery zone, equivalent to the left subclavian artery zone, or zone 2, for the aortic arch. V1 contains the celiac artery and the superior mesenteric artery, equivalent to the left common carotid zone 1 area in the aortic arch. And finally, V0 is equivalent to zone 0 in the aortic arch, and it relates to all of the visceral segments, including the renal arteries, from a TVAR perspective, when one places a thoracic endograph going all the way down into that area. So the usefulness or potential use of this is actually several-fold. I think it's helpful to define these landing zones that are so important in endograph technology to predict success and define success, because it's all about fixation and seal, of course, with endograft intervention. I think it's going to be helpful in preoperative planning for documentation and reporting, but more importantly, overall, it seems to me that it makes a lot of sense to develop a common language, if you will, whereby we can all understand each other as to what we're talking about when we describe these procedures and things related to that. Granted, there are limitations, and it's not perfect. Most of the limitations relate to anatomy that, as we know, not just for the aorta, but anywhere else in human anatomy, variations appear to be the rule rather than the exception. Essentially, there are countless possibilities, even in the visceral segment, as you can see there, with common origin, for instance, of the celiac artery and the superior mesenteric artery, various levels and multiplicities at the renal artery level, etc. The Society for Vascular Surgery published more recently than that paper their reporting standards proposed for TVAR. And they used a slightly different scheme, as you can see there, that they proposed, simply continuing numerically what we had done 10 years ago for the aortic arch. It is another way of doing this. To me, that is not as meaningful as what we have proposed, but who knows, at the end of the day, which one will prevail. Perhaps both will come into use. I would predict, at the end of this short talk, that one of the most important applications of some of these ideas and concepts that we're going to see a lot more of in the very near future relates to the spinal cord blood supply. We now have in our hands, and you saw some of that yesterday from that short presentation on Osiris, with the current day 3D reconstruction softwares that are really nothing short of fabulous and unbelievable, the ability to image the spinal cord blood supply in a way that we have never, ever been able to do or to see or even understand. For instance, we now know, and here is one paper to that effect out of Japan, that if you do intra-arterial contrast injection for CT imaging, you can get much better arterial anatomy definition on the spinal cord blood supply with incredible images of the artery of Adamkiewicz, its origin, exactly at what level from the thoracic aorta. For instance, that's a patient with a chronic aortic dissection, and there are cases where one has a choice how much to cover, what not to cover, and it seems to me that some of this information is going to very rapidly now enter into the kind of information that we are going to feel we must have for appropriate planning of many of these procedures, particularly for some of these complex, extensive chronic aortic dissection cases and some degenerative aneurysms as well. Thank you very much for your attention.